we now move on to our next session titled Breaking New Grounds with Innovative OADs Combination in India. To chair this session, I warmly invite Dr. Aswin Surjit, Consultant Physician, Santala Trust Hospital, and Dr. Harish Kumar G, Senior Physician, IHM Hospital, Varanamgana, Pala.
Good morning, senior faculty members, delegates, and my dear friends. So we are going to have a session on breaking new grounds with innovative OAD combination in India. First of all, I thank our Jyotidev Center and the whole team for giving me and Aswin Surjit the opportunity to chair this important session. Our speaker is very dynamic endocrinologist, and he's done MBBS, MD, DM DM and senior consultant and head of department of Aster MIMS Kochi, MD medicine from Trivandrum, DM from KM Bombay, presented in ICE, EC, AP, APPS meetings, and he has published in 25 publications in index journals, 3 textbook chapters, recipient of AR Seth Award, Endocrine Society of India, and is a great organizer, organized secretary for Mentors Update 2017-18, Scientific Committee Chairman Peace Masterclass 2023, organizer secretary Kentacon, co-editor ESI New Chapter, areas of interest diabetes, obesity, and thyroid. And the floor is yours.
Good morning. At the outset, I am extremely grateful to Jyotidev sir and his team for having me here to discuss something about breaking new grounds, the innovative OAD combinations. And I am also extremely grateful to the Chairpersons for the kind words of introduction. So we know that diabetes mellitus is a chronic disease, and if you see diabetes mellitus as such, the data on macrovascular complication prevention is not that robust. So it is basically microvascular complications which are being prevented by aggressive glycemic control, and even in the UKPDS follow-up trial we can see that the benefit on the CV outcomes, CBC outcomes took almost 10 years to develop. So hyperglycemia is not a very significant risk factor for cardiovascular disease, as is evident in many of the earlier studies with the diabetes prevention studies, the diabetic control trials. Although intensive glycemic control significantly reduces microvascular complications, it has failed to decrease cardiovascular events. And we know all the trials like ECHO trial or VADD trial or advanced trial have shown that aggressive glycemic control may not be that much beneficial as far as improved CV outcomes are concerned. And a combination therapy will be useful to prevent the cardiac, kidney, metabolic complications of diabetes mellitus. Nowadays, we are no more glucocentric. We are talking again and again about CKD continuum, cardiovascular, kidney, and metabolic disease continuum, and it is a prevention of complications along with glycemic control, which is the motto in managing type 2 diabetes mellitus nowadays. So it is not only controlling fasting glucose, it is not only controlling PP glucose, it is not only controlling HbA1c, it is also controlling the BP, blood pressure, and preventing cardiovascular diseases, prevention of MASLD, and decreasing weight and prevention of CKD, which are important in the management of diabetes mellitus. So glucose centricity has given way to disease or diabetes modifying drugs. So if I go back to my UG days of around 1996 or 97 or something like that, so the basic intention of treatment was to control glycemia. So to have a fasting glucose of around 100 or ppps of around 140 and HbA1c of around less than 7. So that was what we were trying to achieve. But nowadays, if you see the drugs that have been released across the globe, we can see that it is no more glucocentric anymore. It is the diabetes prevention of complications which we are focusing on, and it is the global, it is the wholesome glycemic control or wholesome management of the patient in which we are focusing upon. So that is how the situation has changed over the past 10 or 15 years. So I think you might have heard about Ralph Diffronso. Anybody has heard? Anybody has heard about Ralph Diffronso? So we know that Ralph Diffronso is the person who suggested ominous octet. So combination subject you will be knowing there are at least 8 pathophysiological defects in the pathogenesis of type 2 diabetes mellitus, and he is the person who has proposed the ominous object concept, and he believes that diabetes mellitus should not be tackled with the insulin or sulfonylureas. It should be with the disease-modifying drugs like a metformin or pioglitazone or a gliflozin or a GLP-1 agonist. So if you ask Diffron, so what will be the ideal treatment for a patient with diabetes mellitus, he will say that you give a triple combination. The beginning is if the patient is having an HbA1c of 6.5 or 7, in the beginning itself you give a combination of pioglitazone plus gliflozin plus GLP-1 agonist. That is what he will tell. So that is how all these drugs can arrest or can reverse or can modulate the pathophysiology of diabetes mellitus, and it utilizes the cardiorenal metabolic drugs in combination. So today actually this is a sponsored talk, and today I am going to talk about the combination of DAPA, gliflozin as well as pioglitazone. How is it going to affect the management of diabetes mellitus and the metabolic complication of diabetes mellitus? And one of the drugs which have gone forgotten in the past few years, probably it's again coming up, is pioglitazone. So pioglitazone, if you see, it is one of the excellent drugs from the pathophysiological perspective. On the initial atherogenic process itself, it is highly efficient. It's a PPR gamma agonist, and it redistributes the fat, and it has got effect on the atherosclerotic process as well. So it's one of the drugs which alters the pathophysiological process of diabetes mellitus. So definitely it should be given more weightage as far as diabetes mellitus management is concerned. So this combination of DAPA as well as pioglitazone has got so many benefits. So one of the studies which has been conducted, because this sort of combination will be available only in India, because across the globe it is very, very difficult to get permission for this sort of combination of DAPA as well as pioglitazone. But here it may be relatively easier, and this study actually addressed at the combination of DAPA plus pioglitazone, and they were aged between 18 to 65 years of age. Patients who are undergoing monotherapy, HbA1c more than 7.5 and less than 10. Test product was DAPA plus pioglitazone, and the reference was the originator molecules. It was 12 weeks study. So it was seen that over and above the monotherapy, there is a significant decline in HbA1c, fasting glucose as well as PP glucose. It is not different for the originator products like Foxig as well as Actos. So that is what the study says, and definitely this is one of the studies based on which GCTA permission was given. Now we will go behind, we will chase what is the rationale in providing this molecule to our patients. So if you ask about HbA1c reduction, so which will be the best drug for HbA1c reduction as such, it may be insulin. We know there is no limit for HbA1c reduction with insulin, that's very clear. But apart from insulin, what are the drugs which can produce a significant HbA1c decline? One of the drugs which can improve HbA1c will be sulfonylureas, and pioglitazone will be one of the drugs which has got a sustained effective HbA1c reduction of around 1.5%. And pioglitazone also has got similar, DAPA also has a similar one, and DAPA around 1.5 and pioglitazone around 1.2%. When they are combined together, there can be enhanced HbA1c reduction. And also beta cell function preservation is one of the aspects of this molecule. So we know that DAPA gliflozin or empagliflozin, any sort of SGLT inhibitors are completely acting independent of insulin pathway. So it acts on the kidneys to decrease the increase the renal glucose secretion, reduce the load on the pancreatic beta cells indirectly, and definitely in that way it doesn't stimulate pancreas, and it can improve the beta cell function, and beta cell function is preserved. Pioglitazone also similarly, it's an insulin sensitizer, and it improves the beta cell function, and insulin sensitivity is also increased by the use of pioglitazone as well as DAPA gliflozin. So these are the benefits of the pathophysiological process of diabetes mellitus if you are giving a combination of DAPA plus pioglitazone. And one of the problems with the DAPA, we have had a lot of discussion about pioglitazone over the past so many years. Initially there came the problem of fluid retention, then came the problem of heart failure, then came the problem of osteoporosis, then came the problem of bladder cancer, and then came the problem of anemia. So we know that these are the problems associated with pioglitazone, and we have always been too much skeptical about this molecule. And if you combine DAPA with pioglitazone, probably we can offset the edema that can happen with the usage of pioglitazone, and even the weight gain that can happen with the pioglitazone can be partially nullified by the use of DAPA gliflozin. So diuretic effects of DAPA gliflozin will be again one of the boosts for using when we are using along with pioglitazone. So what will be the added advantage of this sort of a combination? Fluid retention of DAPA will be tackled by fluid retention of pyrogliflozin will be tackled by the fluid loss of dapagliflozin. Body weight increase by pyro will be compensated by body weight reduction in DAPA. So for a person who is weighing only around 55 kg or something like that, and if you are sure that the patient is having type 2 diabetes mellitus, and if you are reluctant to start the patient on dapagliflozin because of worry about weight loss, and if the patient is already having MASLD, what will you do? So if the patient is too much concerned about weight loss, probably you can give a combination of DAPA plus PYO so that there is no weight loss as such, and the benefit on the MASLD is doubled by the use of combination of this sort of a combination. So that is one of the attractions of this sort of a combination where you combine drugs like DAPA as well as pyrogliflozin, and also blood pressure reduction is also significantly with the use of dapagliflozin. And nowadays, we already told regarding CKM continuum, cardiovascular, kidney and metabolic disorder continuum, and we have to think about organ protection as such. So one of the drugs which has proven to be useful in prevention of stroke is, which is the drug? It is pyrogliflozin. Pyrogliflozin, one study known as IRIS trial, which showed that there is significant reduction in occurrence of TIA or stroke in patients who already had some sort of CV event. So definitely stroke is probably going to come down with the use of pyrogliflozin. CV death reduction, we know there are large, huge amount of data which favors use of gliflozins for the prevention of cardiovascular disease, cardiovascular events as well as heart failure and MACE reduction. And also there is a huge data favoring these sort of molecules regarding CKD as well. And definitely nowadays we talk about MASLD so frequently. So MASLD is the epidemic of the next so many years. That's what I would look at it. So previously, for the past 10 or 20 years, we have been talking about CKD prevention of diabetes mellitus, and nowadays, from now onwards, around 10 to 20 years from now onwards, we'll be talking more about MASLD as well as cirrhosis. So we'll be talking more about FIB-4 score, just like what we used to talk about EGFR recently. So this is what is going to happen. So definitely MASLD is going to be increasing to epidemic proportions. And yesterday I was taking rounds in my hospital in a gastroenterology ward for diabetes mellitus, and we have a transplant center. So we have around 10 patients who are waiting for transplant, or post-transplant patients, around 10 liver transplant patients are there. So I just went through the etiology of CLE. So what is the etiology? In 70% of the patients, 7% out of these 10, it was MASLD leading to cirrhosis. It is not alcohol, it is not hepatitis B, it is MASLD. So MASLD is one of the very important, unrecognized, probably nowadays is getting recognized, but still less recognized complication of all this metabolic syndrome. And I think it's time for us to focus on drugs which can always suppress the progression of MASLD to cirrhosis from F1 to F4. Prevention is one of our aims, and that will be one of the most important goals in treating diabetic patients in the coming years. And even we have talked so many times regarding metabolic memory effect of leukopenias diabetes. So what's the metabolic memory effect? If you are controlling diabetes mellitus very poorly in the initial few years of diabetes mellitus diagnosis, you are going to have negative outcomes in the future. So is there any way to tackle or to alleviate this sort of a generation of poor glycemic memory effect? Any comments? So if you give the patients dapagliflozin or any sort of gliflozin in the first few years of diagnosis, probably you can mitigate the effect of this memory effect. Even if the sugars are not very well controlled with dapagliflozin the first 2 or 3 years of diagnosis, the memory effect is the bad memory effect is not being generated. So it is like this. We have got 3 sort of patients. One, patients who are very well controlled in the first few years of diabetes mellitus. Second group of patients in which it is not very well controlled, but the patient is on dapagliflozin. Third group of patients in which the patient is not well controlled and not on dapagliflozin. So it is said that the outcomes of patients who are well controlled in the beginning will be similar to the patients who are not very well controlled but who are on dapagliflozin. I think this is what I wanted to explain. I think it's clear now. So if you are starting the patient initially itself on dapagliflozin, probably the mitigation of bad memory effect can happen, and that will be beneficial. So probably for a patient who is coming to your OPD tomorrow and who is having an experience of around 7.8 or 8, and if the patient is having no contraindication for starting the patient on dapagliflozin, the patient should be on dapagliflozin. So that's what I wanted to tell you, because the generation of good glycemic memory effect is very high if you have started the patient on dapagliflozin or any sort of gliflozin. And even I already told that there is some sort of effect on the pathophysiological process of diabetes mellitus for pyrogliflozin. So pyrogliflozin is one of the most wonderful molecules as far as the pathophysiological process of diabetes mellitus is concerned. It can directly impact the process of atherosclerosis. The atherosclerosis can be impacted, and it reduces cardiac hypertrophy, reduces inflammation. And dapagliflozin also, basically, it is mechanical effects of dapagliflozin and metabolic effects of pyrogliflozin which are doing the wonders as far as heart is concerned. So mechanical effects like the reduction in preload as well as afterload as well as metabolic improvement like oxidative stress improvement is there with the use of dapagliflozin. And I think this is again, you need not go to the slide, but it's very clear that pyrogliflozin, SGLT inhibitors and their combination therapy can lead to improvement in the CV outcomes. Reduction in the MACE risk by around 24%, MI risk by around 19%, stroke risk by 28%. So here, one thing that you should focus here is the stroke risk. So if you go to EMPARA outcome trial, probably you might have seen that in the subgroup analysis, we can see that there is a mild increase in stroke incidence. But the one drug which is going to be very much effective for stroke prevention will be pyrogliflozin. So pyrogliflozin, if there is added pyrogliflozin, probably you can see that there is a decrease in stroke risk by around 28%, and the rest of the things we know. But here, this point I wanted to highlight. So again, I think I don't know, some people who are in the back might have heard about ADOPT trial. So what is ADOPT trial? ADOPT trial is one of the earlier trials which looked at glyburide, metformin as well as rosiglitazone. It was seen that rosiglitazone provides a maximal durable glycemic control. So that's one of the earlier trials with the rosiglitazone, but it's no more available, and it's very clear that the glycemic control is highly durable if you are putting the patient on pyrogliflozin as well, which is evident in the TOSCA IT trial, which showed that the glycemic durability is more than 5 years. So glycemic durability is an important aspect. So this became very clear when pyrogliflozin was banned around a few years back. So many patients whom I had started on pyrogliflozin around 10 or 12 years back came back saying that this molecule is no more available, because they were not following up with me. The reason is they were very well controlled. Only when it was banned, patients started coming back saying that it is banned and we want another drug. So thing is that the point that I want to highlight is that durability is definitely there. We don't need any studies. It was very clear at the time of banning of pyrogliflozin. And again, CVOT outcomes trials, I think I told about CVOT outcome trials of pyrogliflozin. One is Periscope trial, which looked at the coronary atherosclerosis, the progression of coronary atherosclerosis, and it was seen that it is beneficial. Proactive study, but which failed to achieve statistical significance regarding the CV safety outcome trial, but still there was 16% relative risk reduction in the composite of all-cause mortality, non-fatal MI as well as stroke, and you can see the huge number of patients in the proactive trial. Though it failed to show significance, it showed a decreasing trend towards the development of CV outcomes. Chicago trial basically looked at the carotid edema median thickness, and it was found to be beneficial. And I think I already told about IRIS trial, which showed that there is definitely 24% risk reduction in the occurrence of stroke as well as TIS. And I think it will be superfluous from my side to tell about the CV outcome trials of dapagliflozin. Declared TB, we know it is a CV outcome trial which showed reduction in the heart failure and other hospital for heart failure, DAPA-HF trial, CBD real trial, DAPA-CKD trial, which produced improvement in the CKD outcomes. I think Dr. Vimal M V has already beautifully told us regarding this. And now coming towards the end of this discussion is regarding the parameter that we are looking at in the CKD continuum. If you are looking at stroke, DAPA has neutral effects and pyrogliflozin decreases stroke. MI definitely is reduced by DAPA. CV death, DAPA is significantly reducing it. Heart failure again, dapagliflozin reduces renal disease also. There is benefit for both. And I think a few words regarding fatty liver. Nowadays we focus too much on fatty liver, and I already told FIB-4 score. So what are the components of FIB-4 score? Any comments? It is age, SGOT, SGPT as well as platelet count. So a patient came to my OPD yesterday who was having who is a diabetes for the past 5 years. I checked the CBC. Platelet count is 1.4 lakhs. So what does it mean? It is MSLD. So it is MSLD. So nowadays I think I emphasize so much on platelet count as well. because that point of time, if you do ultrasound and see that the patient has already reached a state 2 or fatty liver grade 2 or 3, and the patient is likely to progress to CLD soon. So platelet count is gaining acceptance, FIB-4 score is gaining acceptance, and you can prevent fatty liver disease by doing aggressive lifestyle modification, as well as Pioglitazone is one of the drugs which is approved for the use of dapagliflozin due to the fat redistribution from the visceral fat to the subcutaneous fat, and definitely in diabetic CLDs, diabetic fatty liver, it is one of the wonderful drugs, and definitely it is beneficial in this combination is beneficial in MASLD. Nowadays, the only drug, FDA approved drug for MASLD is, any comments? It is resveratrol. It is one of the drugs which is approved. There are trials going on with some other drugs like semaglutide as well. Essence trial is there. And for diabetic MASLD, this is Pioglitazone is approved by all the AD as well as DCG approved. And even Biflozins have got some data regarding MASLD reduction, mainly due to the weight reduction due to this drug. So ladies and gentlemen, I want to wind up my talk saying that you resort to drugs which are disease modifying drugs, and when a patient comes to you tomorrow or in a 1 week with a newly diagnosed diabetes, think beyond sulfonylureas and think about disease modifying drugs, and because these drugs has got significant data and stroke prevention, the combination, even you can think about combination, because early combination therapies nowadays very much coming into existence, and Pioglitazone can lead to decrease in stroke. Myocardial infarction can come down with the use of Biflozins. CV health will improve, and CV death can come down. Heart failure, CKD, fluid reduction, the MASLD component, HbA1c reduction, everything you can achieve with the drugs which Defronso told us. Defronso tells us that you put the patient on metformin, Pioglitazone as well as dapagliflozin. I think I always am attracted towards the concepts of Defronso, and I would like to wind up by saying that we should more and more think of using these sort of drugs which can be disease modifying in patients with type 2 diabetes mellitus. Thank you so much. Thank you.
Thank you, Dr. Vimal. It was an excellent presentation, very lucid, clear, and what to say, a pakka professional style, I should say, like an excellent talk as usual. Thank you, sir. And it was also very interesting, and your flow of slides and everything were in order, and we were so more educated, I think, Harish sir also. Any questions from the audience? Please.
Yes, sir. Actually, always Pioglitazone has got an increase in, especially postmenopausal females, osteoporosis is always a risk, and I think in India it is not well validated. There may be some other reasons, but there is definitely, because of the fat redistribution, there can be increased risk of osteoporosis, but always you have to weigh. Mainly it is the postmenopausal females, and if the patient is having significant MASLD in a diabetic, and if you weigh the risk of osteoporosis as well as MASLD, probably you may give more weightage. So that's up to you to decide whether you should give more weightage to MASLD component or give more weightage to osteoporosis. But in especially postmenopausal osteoporosis already demonstrated one, probably I may not be considering Pioglitazone, but otherwise in a female who is otherwise well maintained, probably you can think of starting Pioglitazone as well. Definitely the point is well taken.
Yeah, Pioglitazone is a great molecule, and really highly proponent of this, because most trials actually, like pharma is not promoting this because this is not very, costly molecule. But as per ADA, 2025 guidelines, in pre-diabetes, diabetes, MASLD,
yes,
the first line is GLP-1, the second is Pio. After GLP-1, not even SGLT2.
It's not SGLT2.
Yeah. So and most of the diabetic patients have diabetes with MASLD, which is very, very common, 70 to 80%. So Pio comes even before SGLT2, and as per Defronso, as you rightly said, but now metformin is out.
Yeah, metformin is
out. So the best three medications, if you want to give and patient can afford, is GLP-1, SGLT2 and
Pioglitazone. It's not metformin. Metformin is not there actually, as per his algorithm. Actually, I had an opportunity to talk to him as well. So metformin is not there actually. These are the things. You are right.
Class 2 cardiac failure.
Yes, sir. Actually, that's what. The thing is that heart failure with Pioglitazone will be partially offset by the use of dapagliflozin. As such, heart failure data with pyoglitazone is not that huge. Actually, it's the fluid retention and which is there in heart failure as such may not be that, and we don't have any actual data with this sort of a combination. There is no even real world studies are not there as far as heart failure is concerned. It's not possible for us. So it's your judgment. Patients already having heart failure, I will not give pioglitazone. But patients who are not having heart failure, I think you can give, because the chance of heart failure will be counteracted by dapagliflozin.
Any advantage or lobiglutasone?
Yes, sir, I don't have that much experience, and as per theory, I think I'm not used that much lobiglutasone, so I don't know. And even the international recommendations are not using EVDA. Nobody is saying about lobiglutasone, so I don't know. And personal users is also not there, so I am not able in the position to comment.
We had an excellent session. If there are no more comments or queries, we'll wind up the session. Please give a big clap to Dr. Will for this presentation. Thank you.
What about the long-term safety of pioglitazone? Like long-term safety, there is a risk for cardiovascular and bladder.
Yes, man, I think bladder was something based on an insurance registry that is out. There is nothing like a bladder one that is based on an insurance registry in Germany and so many European countries. That is out. And long term, I think so many patients are using pioglitazone for a long period of time. We are not seeing them because they are having good glycemic control. There's got a durable glycemic benefit, and I think long term data is not that bad. Actually, in our minds, we are a bit biased against pioglitazone. That's what is happening. So in our mindset, because of the earlier problems with rosiglitazone and everything, we are biased. Otherwise, there is no problem in long term as
For example, your experience, cardiovascular.
Yes, actually, if you see the pathophysiology of pioglitazone, pioglitazone actually reduces the atherosclerotic process. In the atherosclerotic process, it reduces and it redistributes the fat, and it is very good for stroke prevention as well. So, in the pathophysiology of diabetes mellitus complications, it's actually a wonderful molecule, pioglitazone. So, regarding the long term, I think even patients have used for past 30 or 40 years of age and 30 years, and it is unlikely to produce any long term cardiovascular negative effects. So, you need not be that much worried about. And if the patient is already having a heart failure, probably don't use it. And already having an MI, pre-existing MI, don't use pioglitazone. Otherwise, normal patients who are having high risk factors for development of cardiac complications, you can use. Patient already had MI or had heart failure, don't use. I think practically that's what we can do.
A big thank you to both our chairperson and speaker. We now move on to our next session. To chair this session, I invite Dr. Arun Shankar, Senior Diabetologist, Jodhidev's Diabetes and Research Center, Trivandrum.